Thank you, Gal, for this introduction. So, as Gal mentioned, I'm a student here at BGU, and along with Gal, my supervisors are Idan Menashe as well. So the topic of my dissertation is factors associated with safety and effectiveness of psychotropic therapy in children with ASD. And today I'm going to present some preliminary results. So as we all know, autism unfortunately cannot be cured, and there is no single therapy that fits everyone. Optimal therapy is a multidisciplinary one and is tailored to the child's specifics, difficulties, and symptoms, with the hopes that early diagnosis and therapy will lead to better prognosis in the future. So the main interventions to tackle the core autistic symptoms of a child are model-based, basically interventions in the terms of behavioral and developmental models. Along with that, additional layers may include paramedical or pharmacological therapies. So pharmacological therapy for children with ASD is quite common. Up to 60% of children are prescribed with at least one psychotropic agent. Obviously, it depends on the child's age. These treatments are usually given for symptoms and comorbidities and not core autistic symptomology. For that, these treatments are less effective. You can see that there is quite a substantial prevalence of these co-occurring symptoms and comorbidities among children with ASD, and subsequently there is a high prevalence of prescription of psychotropics. So the challenges in treating children with ASD are related to the heterogeneity of autism's presentation and etiology, leading to substantial variability of treatment outcomes in children with ASD compared to treatment of children in general population for the same symptoms using the same agents. This is leading to a trial and error approach where a treating physician will prescribe a psychotropic agent and follow up with the kid and see whether they respond positively or adverse events or ineffectiveness will develop, and then the child will be switched to a different agent and so forth. There is a limited evidence regarding children-related factors and characteristics that are associated with treatment outcomes of psychotropic agents. And this is the goal of our study, to extend this knowledge and to identify clinical and behavioral characteristics of children with ASD and their association with psychotropic treatment. Specifically, we focused on methylphenidate and risperidone. Eventually, we are hoping to provide a treating physician with another source of knowledge, something that they can take into consideration before prescribing a specific agent for a child. So the first one, as I said, is risperidone. Is known in Israel by brand names of Risperdal and Respond. It's a second-generation antipsychotic. It's usually used to treat irritability and aggression in children with ASD. It's one of two US FDA approved drugs, the other one being aripiprazole, specifically for children with ASD. Its safety profile is quite established and well known, while its response rate in children with autism is quite variable, with response rates up to 70%. And the second drug that we focused on is methylphenidate. In Israel, sold under multiple brand names, including Vitali and Concerta. It's a CNS stimulant. It's usually used to address hyperactivity and impulsivity in children with ASD. Similar to risperidone, its safety profile is quite established. It's important to note that its response rate in children with ASD is lower compared to children with ADHD alone. So for the study is a retrospective database-based study. One of the databases is the Israeli National Center for Autism and Neurodevelopmental Research database, NCAN. So through this center's collaboration with the clinics that diagnose and treat children with autism, the children undergo multiple assessments and evaluations, and data is being collected and entered into the database. You can see on the slide the variability of the data that is being collected. It's important to mention that this is a growing database with more than 200 families joining each year, and currently there is more than 3,000 children enrolled in this database. So the study sample was taken from the ANCAN database I just described. The children were with a date of birth 2014 and onwards, and children that were treated in Soroka's preschool psychiatry unit. It's a psychiatry unit that treats children up to the age of 8, and then they are transferred to different clinics. And the reason we use this sample is because we had the complete access to these children's medical records. Regardless, it is assumed that patients treated in Soroka, which is the biggest and the only tertiary hospital in the region, are a good representation of the Negev population. So in addition to the information from the ANCAN database, information was also gathered from children's medical records through Soroka's electronic medical record systems. CLICS is the legacy one, which was used for all the records, and Chameleon is the current electronic medical record system. So for children meeting the inclusion criteria for the study, a screening was performed in their medical records for information concerning prescription of psychotropics, specifically methylphenidate or risperidone, regardless of brands or formulation. It's important to note that these are only a recommendation for prescriptions, notes in the doctor's visit summary, and not actual dispensing of prescription. So children that for which information was included and had the documentation of recommendation for prescription, their medical records were further searched and for evidence of effectiveness or adverse events being recorded. This data, along with data extracted from the NCAN database, which included sociodemographic, clinical, and behavioral data, was used in the study. So for statistics, univariate statistics were used to test the hypothesis. So let's go for the results. Start with risperidone prescription. You can see in the table a comparison between children that received recommendation for prescription of risperidone. There were 53 children, 15% of the sample versus 301 children that did not receive recommendation for prescription. There were some significant differences between the two groups. The ratio of ADHD co-diagnosis and intellectual disability were higher among the children that had a recommendation for risperidone prescription. As far as ASD severity, according to DSM, the ratio of children requiring very substantial support was higher among children receiving prescription for risperidone. Moreover, IQ scores, language skill scores, sleep quality scores, and adaptive behavioral scores were worse among children that received prescription for risperidone. Of the children that received recommendation for prescription, we compared, we made a comparison between children that had in their records proof of effectiveness or ineffectiveness in relation to their therapy. Language delay was found to be significantly associated with risperidone ineffectiveness. In this slide, you can see the results of a comparison between children that experience adverse events and those that did not among children prescribed with risperidone. It was found that only younger age at ASD diagnosis and lower mean IQ scores are significantly related to adverse events being recorded in the child's medical records. For methylphenidate, it's similar to risperidone. It's a comparison between children receiving methylphenidate prescription. 49 of them, it's about 15% as well, versus 305 children that did not receive recommendation for prescription. We can see that ethnicity, specifically Jewish ethnicity, was associated with methylphenidate prescription. And unsurprisingly, ADHD co-diagnosis was also associated with methylphenidate prescriptions. As with risperidone, I also compared children who had a positive response to treatment with methylphenidate and children that did not. Younger mean age at ASD diagnosis was found to be associated with methylphenidate ineffectiveness. In comparing children for whom adverse events were reported in their medical records versus children for whom adverse events were not reported, there were no significant differences between the characteristics tested. In our study, the prevalence of children receiving a recommendation for prescription of methylphenidate or risperidone was about 15%, leading to a total of 24% of children being prescribed at least one agent. When we look at the global utilization of psychotropics in children with USD, we're at the lower end of the range. We know that the variability in prescription utilization in children with USD is related to local health system structure, to diagnostic criteria differences, and eventually to the child's age. Since our children were treated in a preschool psychiatric clinic with children being up to the age of 8, it is logical that our prevalence will be at the lower end of the range. As far as factors being found to be associated with drug prescription for risperidone, there were multiple, including co-occurring condition of ADHD, intellectual disability, sleep, language, and adaptive ability difficulties, along with severity of ASD symptomology. For MPH, co-occurrence of ADHD diagnosis and Jewish ethnicity were found to be associated with methylphenidate prescription. When looking at published data on prescription utilization in children with ASD, we found that our results are similar to what's been published. Co-occurrent conditions and severe ASD representation are found to be associated with psychotropic utilization. In terms of association between child characteristics and treatment outcomes, for risperidone, language delay, younger age at ASD diagnosis, and lower IQ scores were associated with negative outcomes, while for methylphenidate, younger age at ASD diagnosis was linked to ineffectiveness. There's little information in the published literature concerning to child-related factors or characteristics that are associated to treatment outcomes. The information I found that exists on methylphenidate is not specific for children with ASD, but for children with ADHD only. So extrapolation is problematic. Eventually, no significant associations were identified. Studies on risperidone that did include samples of children with ASD did not find too many characteristics related to treatment outcomes. Mainly underlying disease and symptom severity were found to be associated with negative outcomes. So for the main limitations of the study, They are related to the fact that it's a retrospective database study with sample taken from one clinic in the Negev region, with the exposure data being prescription recommendation and not dispensing of prescription. Information on daily dose of the drugs was not available to us, and eventually the information on outcomes was not available for every child that received recommendation for prescription. Therefore, we had a smaller N, probably affecting significance of the results. So for conclusion, the results of this study are considered to indicate a possible direction for further research. A prospective study is already ongoing in Soroka with the hopes of overcoming some of the limitations of the current study and provide additional knowledge and eventually might guide a treating physician in psychotropic therapy prescriptions in children with ASD. Thank you.